Thank you for the kind introduction and good day to everyone. I am Dr. Ayedee Domingo from the Ateneo School of Medicine and Public Health. Today, I will be talking about the role of teleconsultation in assisted reproductive technology. These are my disclosures. The objectives of my talk today will be the following: to describe teleconsultation and its role in ART, to define teleconsultation and other related concepts, to discuss the benefits and challenges of teleconsultation for ART, and to present current guidance on teleconsultation for ART. What is teleconsultation? Teleconsultation can be defined as consultation done through telecommunications with the purpose of diagnosis or treatment of a patient, with the sites being remote from patient or physician. There are a number of concepts which are usually associated with teleconsultation. These are telehealth and telemedicine. Telehealth is defined as the distribution or delivery of health-related services and information via electronic format and telecommunication technologies. Telemedicine is more narrowly used to describe remote clinical services, such as diagnosis, monitoring, and treatment. Other terminologies that have been used are e-health, connected health, and digital health. For the purpose of this presentation, the terms teleconsultation and telehealth shall be used interchangeably, as these terms are also used interchangeably in the cited references and in the literature. Telehealth can be delivered using various modalities. First, live two-way or real-time synchronous audio and video. This is what we usually associate with teleconsultation and telemedicine. This allows physicians and patients to see and hear each other in real time to discuss conditions. Next, store and forward, also referred to as asynchronous telemedicine. This is the sending of medical imaging, such as x-rays, photos, ultrasound recordings, laboratory results, and other patient information to remote specialists for analysis and future consultation. Next, remote patient monitoring. RPM collects personal and medical data from an individual and transmits the data to a physician. It may use medically designated handheld or wearable devices such as fitness trackers to collect data remotely, or may use smartphones with mobile applications that use Wi-Fi or Bluetooth to track patients. And lastly, mHealth. mHealth is a general term for self-managed patient care using mobile phones or other wireless technology and does not necessarily involve monitoring by a physician. It is most commonly used to deliver or reinforce patient education about preventive care and provide medication reminders, appointment reminders, and other essential self-care tips that patients should undertake to maintain their optimal health. For reproductive endocrinology, what types of visits or services are offered through telehealth? A study in 2022 noted that such services include fertility consultations, reproductive endocrinology consultations, and reproductive surgery consultations. What is the context of telehealth in ART? Telehealth can be of benefit in the setting of ART because patients need a higher level of access to healthcare services. Multiple consultative appointments are often required, along with frequent office visits for serial ultrasonography and blood draws during an IVF cycle. Aside from that, the majority of infertility clinics are usually located in urban areas and in densely populated cities, representing a geographic barrier to access for patients. Given that context, what are the benefits and challenges of telehealth in ART? Unfortunately, few studies have been done on the use of telehealth for ART, but results suggest that telehealth can be implemented in the setting of ART to reduce the burdens associated with travel and cost. One retrospective cohort study conducted in Spain sought to investigate the clinical advantages of using telehealth in the setting of ART. It demonstrated a significantly reduced wait time for evaluation and treatment, with no difference in pregnancy or complication rates. Median wait time until first consultation was 68 days for those who utilized the telemedicine service, while it was 180 days for those who opted for in-person consults. Median wait time until start of treatment was also significantly reduced in the telemedicine cohort, with a median wait time of 169 days, whereas it was 229 days for the control group. The pregnancy rate in the telemedicine cohort was 29.9% and 31.1% in the control group. The differences in successful pregnancy between groups did not reach statistical significance. A much earlier study in 1993 described the successful use of 36 satellite ART programs for local monitoring in patients living remotely from an IVF center in Mayo Clinic. Similar to the previous study, it demonstrated no differences in treatment outcomes between the satellite and central unit groups. More recently, a study in 2021 demonstrated the following benefits in the use of telehealth for ART: reduction in barriers to healthcare access, with similar or comparable treatment outcomes to in person consultation, and high patient satisfaction. The study showed that telehealth significantly reduced the frequency of travel during ovarian stimulation, with a reduction in the number of office visits to an average of 3. These are initial visit or review of IVF consent form, oocyte retrieval, and embryo transfer. Results show that telehealth may reduce financial and physical burden of travel compounded with unpaid time off work. The overall clinical pregnancy rate for telehealth patients was 60% and the live birth rate was 44%, which was not statistically different from the control group. Based on these findings, telehealth may serve as a promising tool to reduce geographic barriers without compromising quality of care. This was also the first study to investigate patient satisfaction using telehealth for ART cycles in the United States. Initially, 79% of patients revealed that they were unaware that telehealth was offered at the institution, but subsequent knowledge was a factor that positively influenced 67% of patients to proceed with necessary ART treatment. Patients demonstrated a high satisfaction rate with telehealth for their IVF cycles, with a total of 72% saying that they were moderately to extremely satisfied. The study also noted that, interestingly, survey participants reporting dissatisfaction were noted to have poor reproductive outcomes, including lack of clinical pregnancy or pregnancy loss following embryo transfer, which could have contributed to their dissatisfaction. Overall, 88% of patients who underwent ART using telehealth stated that they would recommend the service to others. This high patient satisfaction is echoed also by other studies. A study in 2021 had more detail regarding patient satisfaction regarding telehealth. Among in-person consultation, telephone consultation, and video consultation was chosen as the top preference for consult modality. In terms of the ideal mix of modalities, the top preference was to have a combination of telemedicine and in-person consults, with the majority of consults as being in-person. Other results from the study were that higher household income was associated with greater preference for video telemedicine. Overall, satisfaction was very high, with a median score of 5 out of 5. Similar to the previously cited study, having a previous telemedicine consult was associated with a higher preference for telemedicine in the future, signaling greater comfort with this modality with prior experience. This suggests that Awareness and trial of telemedicine can possibly play a key role in its future adoption. Aside from patient satisfaction, provider satisfaction with the use of telehealth has been shown to be high as well. 216 individuals from the Society for Assisted Reproductive Technology Clinics and the Society for Reproductive Endocrinology and Infertility were surveyed and showed that at least 97.2% of providers were at least somewhat satisfied, with a majority of 66.2% as being very satisfied with the use of telehealth for ART. Despite the benefits cited above, challenges were also noted. Many providers found that telehealth services can be burdensome when taking into account insurance coverage and reimbursement of services. Another commonly cited problem was professional licensing in the context of cross-border practice. What are some current guidance and guidelines on the use of telehealth in ART? In 2020, the Presidential Task Force on Telehealth of the American College of Obstetricians and Gynecologists published a committee opinion on recommendations and general guidelines in implementing telehealth in practice. The opinion recommends that obstetrician gynecologists and other physicians who provide telehealth should be knowledgeable on laws regarding telehealth credentialing, reimbursement, and other issues. They must also ensure compliance with relevant data privacy and security regulations, encryption, and other security precautions. Those intending to perform cross-border practice should familiarize themselves with the countries or states that they intend to practice in and ensure that they have reciprocity in terms of licensing, for example, in the case of mutual recognition agreements. Practitioners must also determine if the national health insurer or private insurers provide coverage for telehealth and teleconsultations, and if such services are indeed covered, determine whether they are at par with in-person consultations or services. One way to foster the adoption of telehealth would be through what are known as telehealth parity laws, which require insurers to reimburse teleconsultations with the same rate as in-person consultations. This ensures that telehealth is not perceived as inferior or substandard to face-to-face, in-person delivery of healthcare. Practitioners should also ensure that they have the necessary equipment and reliable and secure internet connectivity to ensure quality care and patient safety. Lastly, and if applicable, ensure that malpractice insurance policies cover telehealth malpractice. In 2020, ASRM and ESHRE released patient management and clinical recommendations, and they recommended limiting in-person consults and instead using telemedicine during the start of the pandemic. Telemedicine continues to be widely used, even as guidelines have allowed for more in-person appointments at infertility centers. The recommendation noted that during the height of the pandemic, telemedicine was instrumental in improving access to care while maintaining social distancing to decrease the risk of transmission of COVID-19. And it adds by saying that telemedicine offers many advantages for patients and physicians alike in the delivery of quality care and should be encouraged and supported to facilitate and maintain improved access. However, limitations were noted for providing telehealth services due to medical licensing or liability issues. In 2021, the Technology and Practice Committees of the ASRM released a guidance on using text, email, and video communication in practices devoted to reproductive medicine. The ASRM COVID-19 Task Force strongly encouraged the use of telehealth in lieu of in-person visits. In the guidance document, ASRM outlined potential uses and benefits, potential pitfalls, and requirements for email and video conferencing in reproductive medicine. The following information pertains to email, but can be useful as well for teleconsultation in general. What should providers consider when communicating with patients by email? One potential use is for the transmission of previous medical records and test results. Patients often express frustration with transmission of their medical records, and such information can be sent via email. However, the provider must ensure that confidentiality, integrity, and availability of the patient's data is protected. Another consideration is as a follow-up to a visit. A response to a patient's query can be given after a synchronous visit, whether in person or through teleconsultation. Email presents a number of uses or benefits. One is patient flexibility. This allows access to a patient's data in advance or after an in-person visit or consult. Another is provider flexibility. Electronic communication can be more timely in the transmission of patient's information, and answers to frequently asked questions can be given more easily. Enhanced communication. Patients can ask questions that they may have forgotten to ask during the consult, and likewise, physicians can provide follow-up information that they failed to communicate. Patient education materials can be more easily sent this way, such as infographics and brochures. Electronic communication can also enhance availability, making it easier to find a common schedule between the patient and the provider. Real-time reporting or communication of test results may reduce the time needed to inform patients of such information. Lastly, and more in relation to the pandemic, there can be decreased number of patient visits, which can decrease the risk of disease transmission. Nonetheless, email can come with a host of potential pitfalls as well. There can be unrealistic patient expectations. Patients may have unrealistic expectations of physicians replying within a few hours or even within the hour to their messages, and may think that physicians can be contacted at any time of the day or night. Physicians should therefore consider placing warnings that email communication should not be used for emergencies or urgent communication, and that teleconsult hours can only be entertained during particular hours of the day. Assumption of a single point of communication. Patients may falsely believe that physicians can only be contacted by email and rely on email as the sole method of communication. Misunderstanding. This is by far the most common and potentially the most dangerous pitfall. Since email and many other forms of electronic communication, such as text messaging and instant messaging, are just plain text, there can be a lot of misunderstanding since messages are devoid of nuance, intonation, and facial expression. Depending on their mood or context when they read the message, patients and physicians may inadvertently ascribe meanings to text beyond what the sender actually intended. Gaps in team information. Email communication is usually external to the patient record, so it is possible that data may be left out, such as treatment advice that was provided in email but not reflected in the patient's chart. All information should thus be captured in the patient record, which shall be the sole repository of the patient's data. Burden on staff or the physician. Due to the ease of sending email and other electronic messages, patients can sometimes be prone to sending short questions one after another or in bursts. Such communication can easily flood a physician's inbox when this can actually be more easily answered during an in-person consult. Security and privacy. Email messages and/or attachments such as test results may sometimes be unsecured and unencrypted, posing a risk to the confidentiality and data privacy of the patient. Reimbursement and billing. Billing of email conversations or text messages can pose a challenge, especially as there are usually no standard rates for such. Lastly, one consideration is the legal aspect. Electronic communication is part of a digital record and may be discoverable in potential lawsuits. Always be careful with what you share in electronic communication, healthcare related or otherwise. How then can a provider proceed with utilizing teleconsultation for patients? There are numerous references, but one can begin with a webinar by ESRM entitled Telehealth During the Pandemic and Beyond, a tool for your clinical arsenal. ASRM presents a number of practical information on how to start and conduct a teleconsultation in general. The following checklist for starting up was recommended in the webinar. A video conferencing platform, usually Zoom or Google Meet, or a proprietary platform within an electronic medical record or hospital information system, a high-speed internet connection, good monitor, headset and/or microphone, a quiet and private place to ensure patient's privacy, background programs on the computer should be off to ensure optimal performance, and optionally a professional image background. To those intending to do telemedicine from their home, the webinar even has tips on how to look good on camera. This one was from Tom Ford, the American fashion designer. Put the computer up on a stack of books or on a stand so that the camera is slightly higher than your head, with the camera pointing down into your eyes. A ring light or lamp can be set next to your computer on the side of your face, in line with and slightly behind the computer. At all times, confidentiality and privacy of the patient must be ensured. Informed consent must always be acquired prior to the start of the first teleconsultation. Additionally, teleconsultation should be performed in a private location to prevent passers-by or eavesdroppers from seeing or hearing the consult. The majority of teleconsultations are now conducted using video conferencing, but teleconsultations may also be done through telephone. The webinar also recommends the use of a good headset and/or microphone or telephone. Tips on decorum include beginning with a casual introduction to establish rapport, adjustment of pace and language as necessary, and checking in often and asking questions to be sure that the patient understands what is being said. Aside from the webinar, there are other numerous resources on the proper hardware, software, and website manner for telemedicine. In summary, telehealth can improve access to assisted reproductive technology in underserved areas and populations and result in high patient satisfaction without compromising outcomes. Reproductive health providers should consider telehealth as a safe and efficacious tool to improve access to healthcare. Thank you for listening. For any questions, you may email me here. Thank you for inviting me and have a great day.